Since its advent at the turn of the 20th century, surgical procedures for organ transplants, medication for immunosuppression, and patient care have significantly improved. And yet still today, only 55% of organ transplant recipients survive beyond 10 years. Why? How can we continue to improve this life-saving technique? Are there other biological factors or variables that we need to consider to improve patient outcomes? Hello, I'm Rebecca Gold, and I want to talk to you about gendered innovations in organ transplant, how considering the sex of organ donors and recipients may improve long-term patient survival. As we will see, simply analyzing sex can help a doctor understand which organ donor-recipient pairs will experience the most successful transplant and improved patient survival. In addition to considering sex, we need to understand what role gender may play in ethically implementing this gendered innovation. New research has retrospectively analyzed decades of hospital organ transplant data to examine how sex impacts organ transplantation. These studies divide pairings of donor, the person giving the organ, and recipient, the person receiving the organ, into 4 different categories. 2 of these are matched: female donor, female recipient, and male donor, male recipient, and 2 are mismatched: female donor, male recipient, and male donor, female recipient. In this way, scientists can evaluate which donor-to-recipient combinations lead to the best transplant outcomes. Furthermore, current and future studies are researching the underlying biological mechanisms that may lead to these varying successes. Some current possible explanations for ways in which organs have a sex are hormone and immunological differences between men and women. For example, female recipients may produce an antibody known as the HY antibody that works against protein markers of the male chromosome on the surface of the male-donated organ, which may lead a woman to reject the organ. Another possible explanation for ways in which organs have sex are variations in organ size or volume. The assumption is that female organ donors are smaller by size and weight. To address how this gendered innovation has been implemented, let's look at the case study of analyzing sex in heart transplants. In 2011, a study analyzed patient survival records from 857 heart transplants. Researchers divided the data into the 4 donor-recipient pairings and evaluated patient outcomes up to 10 years post-operatively. This study found that after 10 years, 71% of sex-matched females who received a female donor's heart survived, as compared to 58% of sex-mismatched females who received a male donor's heart. Similarly, 69% of sex-matched male organ recipients survived, as compared to 59% of sex-mismatched male organ recipients. The study estimated that overall, men who received women's hearts were at a 50% increased risk for mortality than men who received men's hearts. Ultimately, the data showed that sex matching, that is, matching the sex of the donor and the sex of the recipient, provided best long-term survival rates. These findings were substantiated in 2013 in one of the largest studies to date. This study analyzed the survival rates of about 68,000 heart transplants 15 years post-operatively. Once again, both sex-matched donor-recipient pairs led to the best long-term outcomes. After 15 years, 37% of sex-matched female organ recipients survived compared to 35% of sex-mismatched, and 33% of sex-matched male organ recipients survived compared to 29% of sex-mismatched. Now let's consider the ethical dimensions of organ transplant. In order to implement this gendered innovation ethically, each sex must have equal access to the best organ for their survival. Which brings us to our second gendered innovation, analyzing gender. The frequency with which men and women donate organs and gender differences in patient treatment and lifestyle choices have consequences for implementing the analysis of sex in donor-recipient organ matching. Organ donation appears to vary even by organ type. Donating a kidney is considered an elective or spontaneous organ donation. Each person has 2 kidneys, and a donor can survive with just 1. Interestingly, women are 28% more likely to donate than men. One fascinating study suggested that this increased likelihood is based upon the societally constructed ideas of what a woman's role should be. Many women see donating an organ, especially to a family member, as an extension of their familial obligation. The situation is different for heart transplants. Hearts can be harvested only after a person has died. For hearts, 70% of donors are men. Although 75% of heart transplant recipients are male, what happens when a woman needs a heart? It would be incredibly difficult for her to receive the best, sex-matched female donor organ in a system dominated by men. In addition, it has been found that historically, physicians may have added women and minorities to organ waitlists later in the progression of their diseases and even at lower positions, further complicating and impeding a woman patient's chance of getting the best possible organ. Therefore, as a next step, I argue we need to analyze how sex and gender interact. Physicians need to evaluate how sex functions in the organ to be transplanted, i.e., we need to consider whether sex matching is the best model for the patient. Simultaneously, physicians need to address how gender differences impact the supply of organs and the implications of the latter for the former. Moving forward, we must make physicians aware of the gender inequalities in waitlist assignment, or even pass legislation that mandates a timeline for equal placement. Next, we must promote social awareness about the need to become organ donors, so that there are equal numbers of donated organs for each sex. And finally, I suggest that sex should be added to the United Network for Organ Sharing's protocol for organ donor-recipient matching, so that someday physicians may be able to provide the best life-saving care for every patient. Thank you.